Hello, I'm Dr. Anthony Wheeler, and I'm telling you everything that you need to know about pathology. You're probably wondering what's going on in this image. Well, this is a patient in the ICU that is experiencing acute respiratory distress syndrome. Do you see that OG tube? That's because they are intubated. We're going to be discussing this and much more in this presentation on respiratory distress syndrome pathology. This is covered in your book, Medical School Pathology and Step 1 Review. It has everything in it that you need to know about pathology for medical school coursework review and definitely for Step 1. Highly recommended that you utilize it, right? Take advantage of your time and resources. So, acute respiratory distress syndrome. This is typically due to damage to the alveolar capillary junction that is widespread, hence the diffuse alveolar damage. At the microscopic level, you would see edema and the development of hyaline membranes in the alveoli, and that's caused by leakage of protein-rich fluid. Now, what are the clinical features of acute respiratory distress syndrome? Well, obviously, it's affecting the lungs, right? So you can start there. Patient will have respiratory distress, cyanosis, and hypoxia. With acute respiratory distress syndrome, the air sacs collapse and form a type of barrier to oxygen diffusion. Here we can see radiology showing a classic whiteout appearance that occurs with ARDS. Now, some common causes of acute respiratory distress syndrome include medications, sepsis, infections, shock can do it, even trauma, aspiration, pancreatitis can cause it, DIC, as well as hypersensitivity reactions. So these patients that present with this will need an extensive workup to figure out the etiology. Now, type 1 and type 2 pneumocytes are damaged when acute respiratory distress syndrome is occurring. These cells are damaged by protease-mediated and free radical reactions brought on by neutrophil activation. Treatment of acute respiratory distress syndrome must take care of the underlying issue. It must get at that root cause. The positive end expiratory pressure ventilation, or the PEEP ventilation, may be useful in supporting patients with acute respiratory distress syndrome. Interstitial fibrosis can make recovery more difficult because it causes scarring and fibrosis when the type 2 pneumocytes are damaged or lost. Now let's talk about what happens in the younger population, specifically Neonatal Respiratory Distress Syndrome. Neonatal Respiratory Distress Syndrome is respiratory distress brought on by low levels of surfactant. You've heard of that, right? You remember surfactant, how it allows for ease of absorbing oxygen. Well, guess what happens when surfactant is low? Pathology. Air sacs want to collapse. And when the air sacs collapse, it's hard to stay alive. right? Because you need oxygen, obviously. Now let's talk about this. With neonatal respiratory distress syndrome, those type 2 pneumocytes that produce surfactant, they're working in general under normal circumstances. And these cells, the main component of that surfactant is lecithin, also known as phosphatidylcholine. The lung surface tension is reduced by surfactant, which limits the collapse of the alveolar air sacs during expiration. But the lack of surfactant causes the air sacs to burst and hyaline membranes to develop. And keep in mind that neonatal respiratory distress syndrome is related to prematurity. At 28 weeks gestation, surfactant production starts, but it takes until 34 weeks for the appropriate amounts of surfactant to be established. In fact, lung maturity is assessed utilizing the lecithin to sphingomyelin ratio, or the LS ratio, of the amniotic fluid. As surfactant is created, the phosphatidylcholine, aka lecithin, those levels will rise while the sphingomyelin levels stay the same. A ratio of lecithin to sphingomyelin, or specifically an L to S ratio of equal to or greater than 2:1, denotes sufficient surfactant production. A ratio of lecithin to sphingomyelin ratio of less than 2:1 denotes risk of neonatal respiratory distress syndrome. Lack of stress-induced hormones, which promote surfactant synthesis, has led to the implementation of cesarean deliveries in certain patients that may have babies at risk for neonatal respiratory distress syndrome, like those with diabetes, or especially uncontrolled diabetes or gestational diabetes, because that insulin decreases the amount of surfactant that can be produced, okay? Right? That's going to show up, so remember that. To reiterate, insulin reduces the formation of surfactants in maternal diabetes. Highly likely that you will see that. Clinical features of neonatal respiratory distress syndrome include grunting, tachypnea, axillary muscle usage, hypoxemia, and cyanosis. On X-ray, the lungs show diffuse granularity, or you'll hear this buzzword of ground glass appearance. Complications of neonatal respiratory distress syndrome include necrotizing enterocolitis, blindness even, as well as bronchopulmonary dysplasia. The probability of necrotizing enterocolitis and patent ductus arteriosus persisting is increased by hypoxemia. And the likelihood of free radical damage is also increased by the additional oxygen. And note, blindness results from retinal damage. And the bronchopulmonary dysplasia results from lung damage. And with that, you've completed another very important lecture. You are definitely on the right track. You're checking the website, you have all the access you need, you're using your book, you're remembering, you're practicing. You're going to make such a wonderful doctor someday. Keep up the good work, and I'm rooting for you. If you have any questions, comments, or concerns, let me know, and I'll see you next time. Take care.